All right. Thank you everyone for joining us today for our Reese talk. I will do a brief spiel that this does involve some cases. So if you guys wouldn't mind weighing in, putting it on the chat, however, we'd love your participation. We are so excited to have a bunch of geriatric specialists today, two awesome docs who are part of the ED consult team. And I know a lot of you guys asked for this specific topic, so I'm really excited that they were both able to join us. And without further ado, I'll let them introduce themselves and I will chime in as needed.
Awesome. Hi, I'm Kate. I'm a geriatrician here at the university. I did my training in internal medicine here at the University of Colorado and then geriatrics fellowship here. I do geriatrics consults in the emergency room with Dr. Bollan. And that's part of why we're here today. I'm definitely not an emergency medicine specialist, but I do a lot of geriatrics in the emergency room, trying to keep our older adults out of the hospital if we can. Primarily, I do clinic and then also do some nursing home care and then the consults. So I'm all over the place, and hopefully we'll get some good learning in geriatrics tonight.
And hey, I'm Josh. I'm also, Kate and I basically split the geriatric ED consult service throughout the week. I did my training in internal medicine and then fellowship in geriatrics at UC San Diego. And I do primarily inpatient work. I also do a little bit of nursing home work along with Kate, and then I do what our VESPA service, which is our vulnerable adult abuse consult service, and then I do some inpatient time on the geriatric inpatient unit.
Excellent. Well, please feel free to ask questions throughout. I am not a EMS specialist. I never served any time as an EMT or anything, so I hope this is relevant. Please ask questions if it seems like there's holes or things that we can fill in. Really happy to do that. So with that, we'll start with a fall, because you can't do geriatric medicine without talking about falls. It's one of our bread and butter diagnoses. So in this case, you have an 88-year-old male and you're dispatched to a private residence. A patient had a fall and he can't get up, and you guys end up going to his house a lot for frequent falls, unfortunately. So one of the many times you've gone. He is feeling weak, fatigued, and having some pain. He fell 40 minutes ago. He feels worse with palpation of his spine, and it's pretty constant, radiates up and down his back. It's pretty severe, 10 out of 10. It happened about an hour ago after the fall. He has some medical problems. Most of our patients have more than these for medical problems, but just to keep it simple, he's on some blood pressure medicine and a blood thinner and an aspirin. He drinks and smokes. His vitals look pretty good. And next steps. Is there anything you want to know at this point in the case specifically? Anything that's piqued your interest? Or if not, we can carry on. Anything that you particularly do in these situations or what you're worried about right now?
There's neurologic exam because he uses blood thinners and he fell, so he could have something in his brain or something. And now I wanted neurologic exam explicitly.
Me too.
But also, you know, hip or some other fractures because of his age.
Perfect. Any other exam findings that people are worried or thinking about? Okay, well, we'll carry on. We have our exam. So he does have a chin lac, and his mucous membranes are dry. His neck is supple, but he does have sort of generalized tenderness to the C-spine, but no step-offs or deformities. His heart rate is irregularly irregular, but we knew he had AFib to start with. His rest of exam is only really notable for scattered bruising, not unsurprising given his multiple falls that you see him all the time for. And then he also has pained his left upper extremity, but no obvious trauma. I did want to point out just a fun Jerry fact. This picture is a picture of senile purpura, which is a actually normal finding in older adult skin. It is because our collagen and like elasticity in our skin changes over time, largely from sun damage, but also just tincture of time. With any small injury, small trauma, like brushing a door or brushing a hallway, you can get really significant bruising. Obviously, with him being on an aspirin and a DOAC, that's going to be even worse. But just know that this actually can be somewhat of a normal finding in our older adults with that really significant skin integrity change. And then just moving on to his neuro exam, he is alert and oriented. He remembers the whole event, didn't pass out, but his strength in his left upper extremity is decreased compared to his right. Here's his chin lac. Fortunately, not bleeding too much now. Okay, what is your next step for this patient now that you have that information? Is there anything in particular that you're doing for this person at this point that you're most worried about, or next steps in particular?
I would be concerned about bleeding and fractures because he has pain and his left leg is hurting, and I'm a little bit tired because it's 2 o'clock in the morning here. But I would think about fractures and maybe bleeding, and also about his spine because or in his brain, because of his left leg.
Excellent. All
So
very
left laboratory exam and X-ray.
Good. Yeah, and then in the chat we have broken or loose teeth or tongue bite. There's definitely concern for obviously mouth trauma when he's got a chin lac. And other considerations, I think, with tongue being bitten, you can certainly bite your teeth if he really conked his chin. So excellent. Is anyone with him? Great. So you can ask the person that was with him maybe what happened if he can't give a full story or is minimizing the story. Excellent. See spine concerns.
Yeah. And I have a quick question, Kate. On the exam, with the strength being slightly decreased, was that limited by pain, or was that, do we have an idea of that, or is he already in pain and you don't have any idea?
We don't know. We don't know necessarily.
Okay.
Okay. So, these are things you guys do, not things that I do necessarily as a outpatient geriatrician, but you do a repeat primary survey, which looks good. His secondary survey is unchanged. You put a C-collar because we're all a little bit worried about his neck and what happened. Are you doing a backboard for this patient, like full SMR? And I might default to my ED colleagues here too, since you do this more than I do. Any thoughts on how you're going to immobilize this patient in particular, things that you're most concerned about from a mobility standpoint?
I would love some of my folks in my agencies to weigh in on the backboard since they've heard me go off on the C-collar and backboard.
I would not put this patient on a backboard. I would probably, if anything, use a half-back vacuum splint and position the patient in a position of comfort.
Excellent. We've got other comments in the chat too, looking at vital signs, making sure that this person didn't have a stroke, making sure their glucose is okay. One comment about a vacuum mattress, which is not something I know much about, but that sounds good to me. And backboard, maybe consider if patient's able to stay still and calm. And then maybe consider backboard just to move the patient and then take them off of it. Yes, and then obviously concern for stroke preceding the fall or hypoglycemia as the cause of this. All good thoughts. Excellent. Okay, so generally, we're going to talk about C-spine injuries in older patients. So unfortunately, C-spine injuries are the greatest in older adults, C-spine fractures in particular. These are usually actually from a standing or sitting height, so not MVCs. This is, you know, like your run-of-the-mill fall for an older adult. The area of the C-spine that breaks the most is the atlantoaxial joint, so C1-2. It's thought to be because the lower down cervical spine actually gets less mobile over time. So younger patients will have lower level C-spine fractures because that area lower down is more mobile. But as our C-spine stiffens as we age, the C1-2 actually becomes more mobile. And that's why it's at risk of fracture predominantly. There's other things that older people have that put them at even higher risk of atlantoaxial instability. So ankylosing spondylitis, rheumatoid arthritis is a big one. And then a lot of patients have C-spine stenosis. A lot of our patients have osteoporosis, which you'd be more thinking about like compression fracture, but you know that their bone integrity isn't great. And so the patients are just at really high risk of C-spine fractures, unfortunately, because of this anatomical change over time. A lot of these patients end up needing surgical treatment, and the median mortality of that is almost 10%. It's like 9.2% in the studies that I read. And then the short-term complication rate is 15%. So even though we can theoretically fix it with surgery, it's not a benign procedure and really high risk. So that's when your friendly neighborhood geriatrician hopefully comes in and does some goals of care discussions with family and patient about, you know, what we really want to do moving forward. Any questions about that? Otherwise, I'm just going to talk about older adults and falls in general. So you guys have already brought up some really good thoughts on falls and why people fall. So older adults are particularly predisposed to falls, unfortunately. So all these things are diseases of being older. So vision impairment, really, really common in our patient population, macular degeneration, cataracts, glaucoma. If you have low vision, you're 2 times higher risk of falls. Hearing loss seems like a weird one, but more than 50% of our patients or older adults have hearing loss. And that's it's very common and it increases in frequency as you age. So people over 85, it's more than 90% have some amount of hearing loss. And just mild hearing loss triples your risk of fall. I don't think we totally understand the pathophys there, but it is a really high risk condition. Neuropathy, so from poorly controlled diabetes or even cancer, also very common in our older adults. General arthritis, so osteoarthritis, knees, ankles, feet are certainly going to contribute to fall risk. Stroke, as somebody already mentioned, if they have a prior stroke, they're going to be potentially hemiparetic and have difficulty ambulating, or did they have a stroke, which is why they fell? Often hard to know, chicken or egg there, unless we get the MRI. Parkinson's disease, of course, is a movement disorder predominantly affecting older adults. The shuffling gait and difficulty with mobility is a big challenge with this disease, especially as it gets further advanced. And often these patients fall weekly or at least monthly. So it's very, very common in our patients. Dementia itself is an independent risk factor for falls. Separate even from like vision impairment, hearing loss, they're at increased risk if you have cognitive impairment. And then polypharmacy, we'll talk a little bit more about as this talk goes on, but orthostatic hypotension is usually something that we cause. This patient's on hydrochlorothiazide, which is a diuretic blood pressure medication, really, really common to cause falls in our older adults. They can't mount a normal blood pressure response when they stand up and they fall. Arrhythmia, of course, is a possibility. A lot of our patients have issues with arrhythmias. Physical deconditioning doesn't happen as a normal process of aging, but is very common. Patients that are isolated, stay at home, aren't as mobile, very, very common. And then geriatricians will often recommend that they use you know, their cane or a walker, but they have to choose to do that. And so often our patients are not participating fully in our recommendations. This is just a like kind of brief list. These are the high points that I always touch on in clinic when I see a patient with falls. And these are some of these we can modify with our treatments. So really, really broad etiology, but you guys really brought up a lot of important things. Definitely ruling out hypoglycemia or like acute causes of fall, like hypoglycemia, stroke. But really, really broad, unfortunately. And so that's part of our job outpatient, is to try to figure out why they're falling and help them fall less. I'll move to the conclusion. He did get C-spine surgery, then he had to go to rehab, and we'll say that he's functioning very well at home now after his falls. He got a geriatrician who took him off his hydrochlorothiazide and stopped his aspirin, so he's on lower risk meds now. Any questions, reflections on that cases that you've had that are similar, questions, anything that we can answer on falls specifically? This is our only fall case. Okay, Dr. Bollan, do you have anything to add?
No, I think that covered it really well, Kate. Yeah, it's just something we see so much.
Yeah.
And it does have a lot of really scary possible acute causes, which you all brought up. Stroke, you know, there's cardiac syncope is something you always have to worry about. And certainly I think that physical exam finding of them being aware through their fall is something that's really sort of an important factor in understanding what happened and differentiating possible causes and what you need to worry about.
Excellent. All right,
And
well,
oh, sorry, I was just going to add from the pre-hospital perspective. So, you know, especially out east, and in a rural setting, we have some folks that, you know, fall and just need help getting up. And we see a lot of calls for that. And so I would just say, keep that in mind, keep all of those possible causes in mind. Obviously, if the patient has decision-making capacity and doesn't want to go, absolutely appropriate to process a refusal. But it's just, you know, there's not quite, I believe one of our ED geriatrics inclined people, one of our docs says that there's no such thing as a mechanical fall, to be careful with that terminology, that sometimes a lot of the time there is something underlying it. So just something to keep in mind when you are just responding to somebody to help them get up after a fall.
totally agree. Okay, next very common geriatric condition is altered mental status. So you have a 76-year-old woman and you're going to a private home. She's altered but conscious and breathing. So she's confused, and this has been gradually worsening over the last few days. She has diabetes and hypertension. She's on diabetes medicine. She's on diphenhydramine, PRN, amitriptyline, and tramadol, and metoprolol. Her vital signs look reassuring. Anything else on first glance that you're thinking about for somebody that's confused, you're coming to their house and you're not exactly sure what's going on? Any like first takes as you're driving there, what you're thinking about for this patient?
I would think a hypoglycemia or maybe a trauma or something.
Good. UTI.
Medication, because she uses certain medications that can do that.
Good. Love that.
Infections of all causes. UTI was mentioned, but I think that like that's a great point. Infection of all cause.
Meds, I see in the chat. Love that.
Hypoxia was mentioned a minute ago.
Trying to know what her baseline is. That's also super important.
Yeah.
Great. Okay. So we get to her house and this is her exam. She doesn't look like she fell, at least from a physical exam standpoint. She's dry. Her heart is regular. Her exam overall is pretty reassuring. She's only ANO times 1, and she's like intermittently trying to like leave and go to like the kitchen, or go to the bathroom and sort of leave away from you guys. Her cranial nerves on testing seem fine, but her speech is strange. Would call it word salad, which is like just sort of like garbled words put together that don't necessarily make sense. And she just seems very confused. Her family says that this is very abnormal for her. She's normally ANO times 4 and appropriate, and lives alone and does just fine. Blood sugars, excellent. Okay, so we're jumping to this. And other things that we want, I see fast, blood sugar level. Excellent. Any other initial diagnostics, therapeutics that you'd want to know?
Metabolic, maybe she's dehydrated or something, or metabolic problem, like salts or something.
Great. Excellent. Okay. So this is a simplified version, stroke exam, excellent, good. Simplified differential, but at least somewhere to start, because confusion can be a lot of things. But we'll highlight these 3 because they're really important and super common in older adults. So delirium, we'll talk about polypharmacy, and then sort of your neurologic emergencies. So delirium is this kind of vague term that actually does have like criteria for a diagnosis. It means that there's an acute change. So this isn't dementia. This is a change from normal. So she was normal and now she's not from a orientation standpoint. And then it's also a waxing and waning mental status. So what that means is like 2 hours ago, she was fine. And now she's really confused. And like another hour from now, she might look better. And it's really this up and down. There's 2 types of delirium. There's hypoactive, meaning, gosh, mom has just been sleeping all day. She doesn't really want to get up. She's not really eating her breakfast, like just kind of out of it and tired. So hypoactive, meaning less activity. And then hyperactive is usually the one we notice as a medical field more because they're a little bit on the agitated side. They're, talking and frustrated and maybe getting out of bed and falling. So delirium is essentially a version of brain failure is kind of how I describe it to family. We have kidney failure, liver failure, et cetera. And it shouldn't be permanent. It should recover, but it sometimes can take weeks to months, especially in a patient that has other risk factors. And it can be really severe. So people can die from delirium, and it's not to be messed with. There are many causes of delirium. This is a simplified version as well. Acute illness is the biggest one. So infection, stroke, like fracture, some acute change.
Metabolic derangements.
Yeah.
That's where the hyperglycemia and that,
Hypoglycemia,
hyperkalemia, those kind of things come in.
Yeah. So like bad medical illness can cause delirium. And then there's also this category of less medical acute issue as much more so like uncontrolled symptoms. So if a patient has dementia and they can't communicate well, and then they get delirious, they really can't communicate well. And so things like urinary retention, like they can't say, I can't go to the bathroom, that can cause them to be delirious. Constipation is the same, pain, thirst, hunger, all your kind of like basic needs as a human, those can exacerbate somebody into delirium. We see that uncontrolled symptoms most in the hospital where we don't necessarily recognize it soon enough. The big risk factors are dementia. So if you have underlying brain pathology, you are at much higher risk of delirium. Advanced age is an independent risk factor for delirium. So as you get older, you're at higher risk. Greater than age 80 in particular is an important cutoff. And then illness severity. So if you're septic and really ill in the ICU, your chances of delirium are much, much higher. So that's delirium in a 30-second spiel that could be its own whole lecture. Does anybody have questions about that in particular? Since it is kind of a Jerry specific topic, I don't want to gloss over that if people had questions about delirium. Okay. The other next topic that's a Jerry bread and butter is polypharmacy, which you guys have already brought up, which is wonderful. So polypharmacy just means too many meds. And this is a really common problem in older adults. A lot of our patients have a lot of medical problems, you know, like 30 plus medical problems, and you give a pill for each one of those medical problems, and suddenly you have 40 medicines. There's no way that you're taking 40 pills and you're not having some interactions. So I had mentioned that she's on Benadryl PRN. People will take that to sleep, or diphenhydramine. Very, very common. Tylenol PM. So many patients take it. Even in our seniors clinic where they have a geriatrician, we have some patients that are taking this. They forget to tell their doctor. Benadryl is anticholinergic, which is not good for older adults. It puts them at much higher risk of delirium, falls, confusion. You want to stay away from anticholinergic meds. There's other thoughts on anticholinergic cascade, meaning maybe you're not on a really bad player like Benadryl or diphenhydramine, but you're on a couple of medicines that are in a small way anticholinergic, and that combination can push you over the edge. So really, as geriatricians, we work closely with our clinical pharmacists, and then we try to, you know, be very mindful about our medications. But that's something that we think about a lot. She's also on the amitriptyline, which is no good for the same reason. So any sedatives are going to be really, really high risk in older adults. So our sleep aids, any benzodiazepines are really, really high risk for these patients. The risks are the same. It's falls, confusion, and increased risk of actually developing dementia. Any opioid has the same risk, unfortunately. And then I put antihypertensives in here too, because we do that to patients a lot. We've sort of mentioned that already, but that they get too many blood pressure medications and they get orthostatic hypotension and have issues from that. So that's polypharmacy. You guys are already clued into that, so love that. And then we'll talk a little bit about neurologic emergencies later, as long as we have time. But I just wanted to touch on older adults fall a lot. So 3 million falls per year result in ED visits. ICH in older adults is 67,000 per year. So obviously much less than, every time you're falling, you're not developing an ICH, fortunately. AFib is super common though. A lot of our patients are on DOACs or apixaban or rivaroxaban. That's 6 million Americans currently have the diagnosis of AFib. And then stroke is almost 1 million per year. So the point is that there are a lot of neurologic emergencies in older adults. They are a high risk group for stroke and hemorrhage, given their medications that they're on, and their just cerebrovascular disease and cardiovascular disease puts them at risk of stroke. So cannot be ignored when somebody has unaltered mental status presentation. In this case, though, she accidentally took 2 times of her pills today. She took them once and then forgot she took them again. The combination of the Benadryl and the amitriptyline didn't do well for her, and so she was very confused. Obviously, she ended up in the emergency room and they did a full workup. And fortunately, all of her emergency concerns were negative, but we did a good med rec and she realized she doesn't use a pill box. And so we gave her a pill box as a geriatrician. So that's our first altered mental status. We have 2 more, so don't worry. Very common, and I just wanted to highlight the delirium as a diagnosis and polypharmacy in particular in this case, because it's what we see a lot. Any questions about any of that so far? We are moving on to dementia next. So if you have other questions, they can come up to later. Okay. So our next is another bread and butter, dementia. This is dementia with behaviors. You have an 85-year-old lady and you're going to a nursing home because she's yelling and hitting staff, and they're asking for help because they don't know what else to do. So this has been going on for about 20 minutes. She has a diagnosis of vascular dementia, high blood pressure, has a prior stroke, diabetes, et cetera, et cetera. She's on donepezil, which is a dementia medication, sertraline, blood pressure medicines, insulin, long list here, oxycodone, PRN. She was a teacher previously, and she currently uses tobacco. Her vital signs are reassuring. From the nursing home, they got those earlier in the day. Okay, what is any different thoughts compared to the last one where the patient was just kind of disoriented, but agreeable? You're going into this moderate disaster of a situation. What's going through your mind? What are you thinking? What meds are you planning on already? Anything off the top of your head? Yeah, sundowning, great thought. Any like backup meds that you're initially thinking of, or are you waiting till you see her?
Yep. Well, and my guess is this is more of a question to the group, that when you see a patient like this, you probably hardly can treat them any different than anyone with acute mental status changes, that you have to approach it largely the same way. Is that reasonable? Yeah. Okay.
Great. Coming in with no biases. Love it. Full approach to the patient. So her exam, she's atraumatic. She's speaking in full sentences, but she's like yelling. You can't really listen to her heart, lungs. She's combative. You don't see any trauma overtly. She's like moving all of her limbs, but she's like yelling and trying to hit you and the staff. So not an ideal situation. I wanted to use this case just to talk briefly about what dementia is and some of the behaviors that go along with it, just for a background. So dementia is an overall term that's pretty generic, and I like this image because it's how I literally describe it to my patients and families. So dementia is a general overall term for a condition of memory loss. And then below the water droplets are different diagnoses of dementia. So Alzheimer's dementia is the most common dementia. We still don't totally understand the pathophysiology, but it is the most common diagnosis. It is your typical slow, gradual reduction in memory, repetitive stories, and progressing all the way to death. Lewy body dementia is Lewy body and vascular are the next most common, and they're the same percentage and also frontotemporal dementia. So Lewy body, as a geriatrician, the biggest thing that we highlight from this is that they often have hallucinations. So they'll have hallucinations of like fires, or small children are the most common. Sometimes they're not concerning hallucinations, and so then we don't treat them. If they are disturbing, then we usually use medication. Vascular dementia is specifically from strokes. So usually the way I diagnose this is I look at their MRI and they've had many, many strokes. They have another stroke and their cognition worsens. Then we say it's probably this accumulation of strokes that is contributing to their cognitive impairment. This is all sort of on a gradation. I think neurology feels very strongly about their criteria, but there's also some overlap too. Frontotemporal dementia is an interesting pathology in that it's often younger patients, and it's really demonstrated by disinhibition. So you won't see this like word finding difficulty or maybe even repetitive stories, but they'll have almost like a personality change. They might be like inappropriate, like hypersexual or gamble. Their spouses will usually say like, I don't know who I'm married to anymore. And that one can have a lot of behavioral challenges. So anyway, just a general overview. There's a lot more to talk about within each all of those, but just so you know that it's like, there's more to it than just the term dementia. And then going through the stages of dementia, you have mild dementia. So usually this means that you are not having significant deficits. You're still able to get to the bathroom. You maybe are still even driving, but maybe having more difficulty. Maybe you're having your daughter help with your finances now or your meds, but you're still able to cook and clean, kind of those more complex processes. Your behavioral symptoms in this category is usually more from a mood perspective. So like apathy, they're don't necessarily have a goal, or you'll see more depression. And then here you'll start to see those repetitive questions, like why does she keep asking you where the keys are? They're right in her hand, things like that, but still pretty functional. And sometimes people with mild dementia are still working. Moderate dementia is much more severe. So once you have moderate dementia, you have inability to do your activities of daily living, or ADLs. So that's like bathing, toileting, all those more advanced things have gone. So like you're not driving, doing the finances, cooking, cleaning, and you can't even really get yourself to the bathroom potentially. This is our category where we see a lot of behaviors. So agitation, aggression, hallucinations, wandering, not sleeping. They might be inappropriate sexually. So this moderate stage is usually where we see the most challenges from a family and a facility-based situation. Advanced dementia means that you are really struggling with your functional status, like ability to even speak words, not walking anymore, can't even sit up, can't smile. These are all like from 7A to 7E is all worsening severity of dementia. At the last stage, you can't even hold up your head. These patients don't really have a lot of behavioral symptoms because they're so advanced that they're really often limited to bed and are much more like sedate usually. And so it's really in this moderate category where we're going to see a lot more activity and challenges. So similar to our delirium discussion, there's often an unmet need. So especially in a facility, stimulation can be a really big issue. Patients like sitting in front of the TV all day, they refuse to go to the activities that are offered, they refuse to go to the dining hall for meals, and they sort of are restless, and that builds up over time, and then they become sort of agitated. Sometimes it's an environmental change. So if their roommate has changed, or they change rooms, or they're new to the facility, all of those things can be triggers. Even like having a new loud activity in the activity room can be disruptive. So being very sensitive to sort of those like smaller changes. And then again, similar to delirium, thinking about, are they having issues with constipation? Are they having issues with urinary retention that they can't explain or describe? And so really trying to think outside the box of where can we help this person feel better, or what else are we not doing for this person? So managing this from a like geriatrics perspective in particular, and like the nursing home facilities do this a lot, the non-pharmacologic management is going to be your first line. So if they're restless and don't do activities enough, you can get them a activity blanket, which is really just a blanket with like buttons and Velcro and like string that they can tie. And it's just sort of an activity that they can do sitting down. And then redirection, et cetera, having family visit, all those things to try to help reduce the behaviors. Of course, reviewing the medical causes. So are they constipated? Do they have urinary retention? Do they have a fracture that we missed because they fell and didn't report it and we didn't realize? Making sure the environment is as good as it can be. Routine is really big, so trying to keep things regular. And then caregiver support is a big part of Josh and I's job, because this does fall a lot on, if they're living at home instead of a facility, the caregiver is the main person that we have to educate and support and provide resources to. So that's like the best case scenario management. There's also medication management that we can do for dementia with behaviors. So randomized controlled trials show that pain medication So we do empiric Tylenol around the clock for patients with dementia with behaviors. SSRIs like citalopram can be used to help with dementia with behaviors. Melatonin at night to help with that sleep-wake cycle. And then antipsychotics are the big one that I think probably you guys have some experience with, I'm expecting. They do have a black box warning, and that's because of increased risk of death from a cardiac cause, as well as worsening cognition and falls. So if you need it from an emergency perspective, haloperidol is IM or IV, which I'm sure you're all very familiar with. Olanzapine is an ODT option, so you don't have to stab somebody with a needle. If you can get them to take it in their mouth, that can be a reasonable option. Risperidone is liquid or ODT, and then brexpiprazole is this new medication that was just officially approved for dementia with behaviors. Previously, we're using antipsychotics off-label, really just sedating our patients. These patients aren't psychotic. They have dementia with behaviors, and we use these as medical sedation, and I think we should be honest about that and say that. Their risks are QTC prolongation. You can get NMS, Parkinsonism, or any other extrapyramidal symptoms, so tardive dyskinesia. That's the years later, they have the orofacial lip snacking. Akathisia is a restlessness. They kind of can't stop moving. Or dystonia, which is muscle rigidity. So lots of side effects, lots of bad things. But if you need it for a patient that is combative, a risk to themselves or others is really our cutoff in geriatrics, then they're reasonable medication to use. It would just be better and nicer for all of our patients if we had, medication that wasn't just sedating and actually somehow treated their behavioral challenges. But I think it really comes back to managing them without medication and how much we can do for them in a day-to-day standpoint to help reduce these behaviors, rather than these emergency situations, which you guys have to deal with. So in conclusion, she did need some haloperidol to participate in her care, and she was actually found to have a hip fracture during her ED assessment. So just an example of, acute agitation, hard to know what's going on, needs to be sedated to be safe for assessment, and they were able to help and treat her in the hospital. Any thoughts or questions about dementia, or if you guys run into dementia cases frequently, if they're this severe? Any questions that we can answer, or Josh, if you have comments?
Yeah, I actually do, and this is just an observation, is that one of the things that I rely heavily on generally with altered mental status, but with patients with dementia as well, is they often scan all of your documentation into our electronic medical record, and it can be extremely telling when you're detailed about what has happened at the place that you pick them up, because we do. You out there in emergency situations manage it, how you have to, and then once they get to us, it is so helpful to have details of what has gone on at the place that you actually picked them up, because it often leads to answers such as this, like a hip fracture or something. That's just a thought.
I have a question. A lot of agencies carry droperidol now rather than haloperidol after the black box warning was lifted, amended, etc. Do you know any data on those two medications, and if there's a preference, and why we often use haloperidol rather than droperidol in the hospital, at least?
I personally don't know the droperidol data well. I know that we use that much more in our emergency room than haloperidol, but I have been meaning to look that up because I've seen it being used a lot more, but I don't have a good answer for that. I'm sorry.
I don't either.
I think I worry that it is, a different agent that probably has similar side effects, and we feel better about using it because it's not Haldol, but I suspect it has similar risks as all of the antipsychotics do. And even brexpiprazole, which is approved, still has a black box warning about increased risk of mortality. There are medications that we tend to reach for because we feel better about using them, but they're often not necessarily better in the long run and have similar side effects. But I don't know the data. I'm sorry.
Yeah.
Oh, that's totally fair. Yeah, that's I don't either. So we will all do our homework.
Yeah, I don't, I think I feel a little ashamed, but I honestly reach for things I'm familiar with a lot of times, which is haloperidol and olanzapine a lot of the time.
ER docs love droperidol. So
Exactly. Okay, great. Well, throw questions in the chat if they come up. We're moving on to more of your bread and butter than mine. Chest pain, which you see all the time, I'm sure. This is a 78-year-old guy. You're going to their home and he has chest pain. This started early this morning. It's worse with exertion, throbbing, pressure, goes to his back and to his shoulder blades. It's only a 4 out of 10. It's been going on for a few hours. So he has a history of coronary artery disease, high blood pressure, hyperlipidemia, diabetes. He's on a beta blocker, hydrochlorothiazide, and aspirin. He currently smokes. His heart rate's a little slow, 56. Blood pressure is 160/86, and he's satting fine. All right, what are your first thoughts, first steps for this gentleman who you know has a history of coronary artery disease? First thoughts.
I would do a lab exam for a myocardial infarction or ischemic event. I would do maybe look for aorta dissection or coarctatio because of the symptoms going to the back. So imaging, do some imaging, and call the cardiologist.
Excellent, great. We've got IV, O2, and monitor in the chat. Okay, great. Anything else you want to know about this patient at this point, or do we feel good about moving forward? Okay. So, this is your EKG. What are our impressions of this? Oh, last PO intake, good.
I know there's a couple people on here that just took Steve's EKG course, so not to call anyone out, but
Good. We're gonna ask some questions. OPQRSTU for pain. I'm not sure what sample is. Any thoughts on what this EKG is showing by chance? Wait. Is this something that maybe you'd call, yeah, YQRS and all leads? Excellent, excellent. I think sometimes, I don't know, I'm sorry, I don't know this, but I thought that you could transmit this to like the ER doctor if you needed to phone a friend.
we are not quite there yet.
Okay.
on most agencies.
Okay, all right, never
Getting
mind.
there eventually, but
Cool.
you guys calling a STEMI alert or no?
More diesel. Does that mean go faster?
Yeah. Diesel.
That's amazing. Great. We're worried. We're worried about this patient. I think that's fair. Excellent. Okay. So, we're gonna move forward. We're worried about this guy. He's bradycardic. We already knew that from his vitals. He's got crackles in his lungs. He is obese. He's got some edema, and his neuro exam is okay. Okay, so we're worried. How are you guys transporting this person? And how fast and where to? The chest pain is getting worse. Cardiology, needs to see a cardiologist. Great.
Yeah.
Excellent. ASAP, yes, agreed. So we're gonna go fast and yep, rendezvous, call for medical direction, good. Okay.
Yep.
So we're going fast, we're worried. We're most worried, I think, about ACS at this point. But broad differential, like you're gonna see with a lot of geriatric medicine. So I like to think of chest pain anatomically. So what are the structures in the chest? That's the easiest way for me to not try to not miss something. But ACS is the thing that we have to think about the most. It's 6 million ED visits annually in the US is chest pain. So you guys see this all the time. Our patients that are over 75 represent 33% of all acute coronary syndrome patients in the emergency room, and they represent 60% of all deaths. So older patients are going to be a large portion of your acute coronary syndrome, and a lot of those patients, unfortunately, are going to pass away. Adverse events from acute coronary syndrome have a higher risk of death by 70% with each decade of age that you add on. And then the other deeply concerning thing, and you'll see this in the next case too, is that the chest pain frequency decreases as we age. So you can have acute coronary syndrome and not have chest pain. Only 40% of people over 85 actually have chest pain as their primary symptom. So that means we have to think about other things like dyspnea, diaphoresis or sweating, nausea, vomiting, syncope. So older adults can sort of hide this as a symptom or have another symptom as the anginal equivalent. So very scary. Aortic dissection, of course, I've seen this multiple times in my short term as a doctor. Aortic dissection is pictured there in the CT scan with the arrow sign. Or severe AS is something we see in geriatrics a lot, meaning their aortic valve is very stenotic and it will cause, can cause acute chest pain. And if you have critical AS, that's like a surgical emergency, procedural emergency. Pulmonary tension pneumo or even pneumonia. Angela astutely pointed out embolism can definitely cause chest pain. Sorry, I didn't have that on the list. This is not comprehensive, but just kind of general things to think about. GI, you can have esophageal perforation if they recently had an EGD or other procedure. And then mild things like GERD or zoster on the chest wall, costochondritis, or compression fractures we can see radiating from the thorax around, or even rib fractures. All things that can be sort of hard to differentiate without imaging, and some are very high risk and some are not very high risk at all. So we rely a lot on imaging in these cases, I think, and then of course labs to further assess. Okay, this gentleman went to the cath lab, thank you cardiology, and he did have some stents put in his heart. He is now going to cardiac rehab and he's back to his normal function. Any questions, concerns, thoughts on chest pain in older adults or chest pain in general? Or Dr. Bollan, if you'd like to chime in on geriatric chest pain.
Gosh, I think it's, it's one of those ones where you take it sort of the same. I mean, I would assume out in the field as well that you sort of start with ruling out all the bad stuff like the dissections and then a lot of times you land on something that's not, ACS or dissection, but certainly I think a lot of the risk factors. And remember, one of the things I would say as a general geriatric principle is when we ask people what risk factors are, one of the things that is really often missed is the fact that age is often the number one risk factor for many, many disease states, including lots of cancers. And so to just recognize that as the population gets older, as you're dealing with older individuals, you actually have higher suspicion for these things, which have a higher prevalence in older people.
Definitely. Costochondritis is just inflammation of the cartilage in your chest wall. So where your cartilage connects to your bone or your ribs, you can get a little like irritation and inflammation there. Cause isn't always known. Sometimes it's like muscle strain can sort of flare up costochondritis. So it's not, there's not always a clear story, but it's usually with chest wall movement. So a good exam is literally pushing on their chest wall to recreate. If it's more pleuritic, meaning like when they take a deep breath and that causes inflammation or pain because you're moving that joint space, that's more reassuring for costochondritis pain than like angina. Yeah, we see that a lot in primary care. Okay, great. We will press on. I hope people are staying awake. Next is abdominal pain, another very common one for you guys. This is a young lady. She's only 66. You're going to her house and her daughter's calling for her about her belly pain. Happened after dinner, eating seemed to bring it on. It's crampy. It's not radiating anywhere. It's pretty bad. 7 out of 10. It's been going on for 3 hours. She's got a history of AFib and diabetes. She's had a hysterectomy. She's on DILT and insulin. She smokes half a pack per day. She's a little tachycardic 107. Blood pressure is 156/98. And otherwise, things look okay. All right. So we're coming into undifferentiated belly pain. Anything else besides the exam? Oh, great. When was her last bowel movement? A+, love that.
That's a great geriatrician question right there.
So we'll say it was yesterday and it was normal, but great thought. Any other thoughts, questions outside of the exam, which we'll get to next? Okay, we're feeling good. We need to see what she looks like. Fair enough. So she's mucous membranes are dry. Everybody today has dry mucous membranes. She has irregular history of that paroxysmal AFib. She is kind of just diffusely tender, hard to localize, but she's warm and well perfused, and her cognition seems to be appropriate. What are your initial worries? Yes, ischemic bowel, great. We're thinking about our possible diagnoses for this lady. Anything else? Right, great question. We'll talk about rigid abdomen. We'll say right now it's not rigid. Any other emergency belly pain things besides ischemia that we're thinking about? Yeah, so small bowel obstruction. Nowhere is specifically tender. She just kind of hurts everywhere. Unfortunately, can't localize, which is, we'll talk about a problem actually with geriatric patients.
But I'm assuming you're thinking appendicitis, which is certainly on the list of emergency abdominal
Excellent.
conditions.
Any other organs that are going to cause anything similar to appendicitis? Yep, colitis, great. Other big one is, yep, cholecystitis, perfect. The 2 organs that get surgically removed frequently. Good. Yep, Excellent. Gallbladder. Okay, any other non-abdominal organ that can cause belly pain? That might cause belly pain, sort of nondescript. Anything else that you're worried about? Yeah, great. Stone, kidney stone, perfect. UTI maybe is UWI. Yep. Okay, great. Perfect. Yeah. So like your bladder's obviously in your abdominal cavity. Maybe it's causing some radiation of pain. GI bleed. Excellent. Often not super painful, but we'll talk about peptic ulcer disease, which is, precursor to GI bleed.
But certainly in the context of GI bleed, right, there's perforated diverticulitis, which is very, very painful.
Yes. Excellent. Okay. All great thoughts. We'll go through some differentials, some additional differentials as well. What are you doing for this lady right now? So her pain's pretty bad. Is she pregnant? Excellent question. I don't think about this ever. She is 16.
I don't either.
She is postmenopausal, thankfully for me and Josh as internal medicine doctors. A great question. What are you doing for this lady that has pretty bad abdominal pain that's like kind of general? Anything medication wise that you're doing for her right now? Good. What are you thinking, Deborah, in terms of position of comfort? Is there anything in particular that makes you feel better about her knees being flexed or not? I think one of the things I see a lot is if movement, like moving, like they'll describe on the way to the hospital hitting car, like bumps in the road, and that's really painful, like out of proportion. That makes me more worried about something bad going on in their abdomen. Yeah. And then if you can't lay flat and if you're kind of like in a more hunched position, more common with belly pain. Excellent. Are you guys doing fluids for this lady? I don't know. I'm curious. Urine is okay. It's like, light yellow. Is this a patient that you'd normally start an IV and give her medicine on the way, or would you just transport her and monitor her vitals?
Always IV.
Love that.
Okay.
Could get worse.
That makes
Great
sense.
planning.
That makes
Yeah,
sense.
history of lymphoma, good, excellent. So bulky lymphadenopathy or bulky disease in the abdomen can cause obstructions or a lot of other problems. All right, so we're going to give her an IV. This broad differential, we already sort of mentioned, again, similar to the chest pain. Mesenteric ischemia has to be on your list. She already has a history of AFib, we know that. A rupture is a possibility. So if they have a AAA that ruptured, that can be really painful and they'll be very, very sick. Bowel obstruction we mentioned, diverticulitis we mentioned, appendicitis we mentioned. Interestingly, in the realm of perforation that Josh brought up, mortality with perforation is 30% for older adults compared to 10% in the general population. So very, very high risk for older adults. And then rigidity is typically absent in almost 80% of older adults with perforation. So we would like to think of like rigidity and our good abdominal exam as like a truth-telling exam finding, but it's really not. So older adults have decreased abdominal musculature. We've kind of talked about like muscle atrophy earlier in this talk. And so you can't use rigidity as a rule out for something bad going on. And then interestingly, 35% of patients over 60 with peptic ulcer disease don't have any abdominal pain, compared to like 8% of people under age 60. So again, this like pain presentation is often hard to suss out for older adults, and they often won't even have pain when you expect them to. Similarly, not following the textbook for cholecystitis, 40% of older adults won't have nausea or vomiting. So again, those cues that we use may not be evident in older adults. And then pancreatitis is something that we actually see pretty frequently from an abdominal pain standpoint. Your risk increases 200-fold after age 65 for pancreatitis in general. So really, really common. And then other things to think about that we always think about is like non-abdominal causes. So is it an MI? Is it like an atypical presentation of ACS? Do they have, you know, like lung pathologies or cystitis, which was brought up, which is great. So again, very, very broad. I think you have to think of them as, you know, presume potentially something bad, and then the, you know, emergency room can sort of try to suss that out with labs and imaging. But patients often don't look as sick as they do once we get a little bit more data. And so that's what I wanted to talk about a little bit with this topic. So sepsis in older adults can be really tough to realize how sick they are until it's really too late. So we do have a decreased immune response as we age. That's just part of our immunology, like immunologic response to disease. So you might not get a fever. And so, you know, everyone says like, it's a fever for me or whatever. Truly for older adults, they might not actually get up to 38 and still technically have a like inflammatory process going on. They might not have a high white count, again, because they're kind of effectively immunosuppressed. And then problematically, like this lady, might not have focal symptoms. So they might not have that right upper quadrant abdominal pain or that right lower quadrant abdominal pain, because again, their immune system response isn't the same as when we're younger, and all of our immune cells go to that one spot that's infected or irritated. They might not have that. Similarly, they might not develop abscesses in the same way. And so on imaging, we might be tricked into saying, well, they don't have an abscess, when really they are actually quite sick. Again, we talked about the broad differential, given usually these patients have a complex past medical history. We talked about, you know, lymphoma, history of diverticulitis, ACS, all these things. And so my default is to trust the patient and the family. So I had a case that was actually quite similar to this. Patient came into clinic in his 90s, just didn't feel right, but didn't have any sort of focal symptoms. I got labs and a chest x-ray, and he actually ended up having ascending cholangitis, which is what I decided this lady had, with generalized abdominal pain, otherwise feeling okay. She had stone blockage from her gallbladder. They had to go in and release the stone, and then all the infection sort of drains out of the gallbladder. This is a very high risk, high mortality condition if not treated, and does happen in older adults with sometimes mild symptoms. So again, not to scare you into thinking all older adults are going to have some emergency always, but it is interesting that they often don't present in a classic way. Josh, any take-home points or something?
I mean, I think that alone is a huge take-home point. It is also one of the things that makes taking care of older patients, you know, fun, is that it really takes a lot of information and a lot of really careful history and sort of careful observation to come up with diagnoses and clinical impressions. And I think I wouldn't, from everything in this is one of the really big ones, is that like altered mental status is often a presentation of many of these diseases, pneumonia or acute abdominal conditions. It's just such a classic, and it makes it cool because you really rely on your exam and the history to make a better diagnosis or to come up with a diagnosis. Also,
Anyway.
I do have to go, but
Thanks, Josh.
yeah, absolutely. Thank you, Kate, and thank you, everyone.
Any other questions or thoughts on this case, concerns, stories? Okay, we'll move to something that's near and dear to my heart. This patient's short of breath. She's 95. And you're going to her assisted living facility. They called because she's short of breath. So started this morning. It's worse when she moves around. It's been going on for about 12 hours. She has bad COPD. She's had a lobectomy. She uses inhalers and a duonaber like the highlights. She is a former smoker. She's tachycardic to the 150s. She's hypertensive, 180 over 110. She's hypoxic on her baseline oxygen of 6 liters, and her end tidal CO2 is 50. Thoughts, worries, impressions initially for this lady? Sick or not sick, I think is a good question here. What do you guys think? Very sick. Agreed. Sick. Yes. Good. Sick lady, based on her story and her vitals, definitely concerning. Excellent. So you do an exam. She's tachycardic. We already knew that. Regular rate or regular rhythm, excuse me. She does seem to be in respiratory distress. She doesn't have good air movement. She has expiratory wheezing throughout. She's not really speaking to you. She has cool extremities. But when you do prompt her, she's able to tell you where she is and who she is. What are we worried? Lung sounds, yeah, good. So some wheeze. What are you guys worried about at this point? Anything in particular that you're most concerned about? Yeah, heart, lung, COPD, excellent. CPAP instead of non-rebreather, okay, excellent. We're thinking about therapeutics, good. Pneumonia is a differential, fabulous. Excellent. Okay, those are all really, really good thoughts. We've already sort of mentioned this. Yep, getting acidotic and not ventilating. Excellent. So I'm curious if people could speak up on this, because it is something that I'm really interested in. She has this green form. Where are you finding these for most of your patients, if you're finding them at all, or if you don't know what this is, I will definitely talk to you about it today. Where do these show up for you? Because I know where I tell my patients to put them, but I'm curious in reality where they end up and how you find them. On the fridge, great. Buried under a bunch of other grandchildren pictures, probably. Family has it, good. Okay, that's good to know. Any time that it's like by the bedside, is that a spot or not really? Okay, I'm gonna say no based on, oh, wallet or purse, interesting. The hospital will have it, yep. Covered in meds, yes, I believe that. Okay, great. So it seems like you guys are familiar with this, but this is something that I do a lot in geriatrics and a lot actually in the emergency room, is talking about goals of care. So there's a bunch of different advanced care planning documents. This green one is the one that we're talking about, the most form. It's also called a PULSed form in other states. And there's 3 questions. One is about CPR, 2 is about the advanced level of care that they would want. And then the last question is about tube feeding. So the middle option of like what level of care you want, it's like comfort care only, so keep me comfortable, don't cure my disease. Selective treatment is, I'd be okay going to the hospital, but I don't want to go to the ICU. I don't want to be kept alive on machines. And full treatment is do everything you can. I want to stay alive as long as possible. And these are filled out usually with primary care, usually with the patient and or MDPOA, depending on if patient has capacity to fill them out. They are really important because if patients don't want to go to the hospital, this is where it's going to say that. So comfort care, when I check that box for a patient, that means they don't want to come to the hospital anymore. They just want to be kept comfortable. If they can't be kept comfortable at home, then of course they can come to the hospital to be kept comfortable. But hopefully if a patient is really sick and has comfort care selected, then they are on hospice. And we'll talk about that a little bit more. There's a couple other versions. So 5 wishes is kind of a more detailed approach to what level of care you would want. It's not this kind of quick and dirty 3 questions. It's much more detailed and goes into what you would want, if then, how I would want my medical care to be. There's also living wills that people draw up with lawyers. And then the last form that I couldn't find a good example of because there's a bunch of different types in Colorado is an MDPOA form. So you're probably familiar, but in Colorado, there's no standard decision maker. So in a lot of other states, it's your spouse or your parent if you're a child, or sorry, a young adult, it's your parent. It's like your next of kin that seems to make the most sense in terms of who the decision maker is. In Colorado, that doesn't exist. So in Colorado, there's something called all interested parties. So if you don't have an MDPOA filled out saying, I want my spouse to be my decision maker, technically the medical system, and you're too sick to make your own decisions, technically the medical system has to call all interested parties, which is usually your extended family, and sometimes it's like a neighbor or your local bartender or whoever it might be. And we have to get those people all together to agree to identify a proxy decision maker. So a one person that's going to help make our decisions for you. If you don't have an MDPOA, I would strongly encourage you to fill it out, even though you're young and healthy, because there is not a default person in Colorado. Anyway, these are all sorts of the documents that we developed with our patients in primary care, and then of course are relevant to you all because of that CPR question and that should I transport to the hospital question. And then if the MDPOA is present, you can obviously chat with them as well. I'm sure that finding MDPOA paperwork in a critically ill patient is very difficult. But that's kind of a brief overview on advanced care planning documents that patients will have. So just briefly, you may or may not be familiar, but hospice is a specific service that is provided to patients that have less than 6 months to live. There's 2 different forms of hospice. So there's outpatient hospice, meaning you're in your home or a nursing home. You're not in a hospital. And a nurse comes usually like once or twice a week. And then otherwise your family does all the cares or the nursing home does all the cares. And if you have an emergency in the middle of the night, there's somebody you can call. But it's not 24-hour care. It's not a nurse aide 24/7 with you. It's unfortunately really just access to an RN that can help you manage symptoms over the phone and then check-ins once a week usually. So that's why a lot of families end up taking their family members to a nursing home because the needs at the end of life are too great for people to handle at home. The next option is inpatient hospice. So that's actually a physical building that only does hospice. And that's the patient needs to have requirements for like IV meds, IV like pain meds or other symptom management that's not controlled at home. That's usually patients that are actively dying go to inpatient hospice if their family can't manage with the medications they have at home. And then unfortunately, the way that the payment structure works, Medicare pays for hospice, and usually if a patient comes to the emergency room, that hospice will discharge the patient and from the hospice care, and they can re-enroll later, but it is a negative, I would say, of an emergency room visit. And so our general philosophy around hospice is that if you don't want to go to the hospital anymore, you don't want to continue seeing doctors for curative treatment, then hospice makes sense for you if you have less than 6 months. But if you still want to come to the emergency room and you still want antibiotics or to be on a ventilator, then hospice doesn't make the most sense for you. And so when patients are in crisis at the end of life, that's where the hospice nurse over the phone can be really helpful and help avoid a very stressful emergency room visit and really help titrate those meds at home. I did want to just put in a plug too that hospice is like a subset of palliative care. Palliative care is a broad term for symptom management, a specialty that addresses chronic illness and symptom management. So a lot of patients can qualify for palliative care, and then a small subset of those palliative care patients will qualify for hospice if they have that limited life expectancy. Things that I'm sure you know, but I just wanted to touch on, the medications that they'll have in their tool belt are going to be things, morphine is the most common, it's sublingual. They're going to use that for pain and air hunger especially. Lorazepam can be used for anxiety, nausea, and terminal delirium. Haloperidol is used for terminal delirium. Scopolamine is used for nausea, so is Zofran or ondansetron. And then secretion management ends up being a big challenge really at the last few days of life, and you can use glycopyrrolate or atropine drops. And so for in this situation, the patient is really struggling, but the hospice nurse actually meets you there by the time you arrive, and you work together to administer some morphine to keep the patient comfortable, and provide some support to the family during that challenging time. So this one's just near and dear to my heart because I hope that my patients don't get transferred to the hospital if they are on hospice and if they don't want to go back to the emergency room, largely because of the stress associated with the transport and the emergency room visit in general. And so the hospice nurses are a wonderful resource that we use a lot to help through those really challenging times. But I don't know if this is a frequent call that you guys get, but just know that the hospice nurse is a resource if you're feeling uncomfortable with next steps in management. There is somebody that you can get a hold of 24/7. Any questions or thoughts on hospice and end of life? Okay. All right, last one. Thanks for hanging in. I promised we were going to talk about more altered mental status. So this is a 72-year-old lady. She's in a skilled nursing facility, and she's more altered than her baseline. She became altered 2.5 hours ago, and she's altered. I'm curious how often this comes up and if this is a question that you guys ask a lot, because it is relevant to a lot of medical problems, especially cognitive change. Yes, Nikki says, yes, we do. Excellent. What is the reason you're asking usually? Or what are you thinking about next steps? Maybe the emergency doctor will want to know. It's a good reason to ask. But the big reason that I'm sure you guys all know is that to establish a baseline and to know when things changed and what we can do next. So it really changes like how fast you need to get somebody somewhere, where they should go, like what kind of hospital, and really if they're eligible for certain like stroke treatments is the big reason. So this lady has dementia, has had an appendectomy, is on blood pressure and diabetes medicines. Vitals are reasonable other than a little hypertensive. How fast are you transporting this gentleman? Sorry, it's a gentleman, not a lady. I'll tell you that his speech doesn't really make sense and he can't name objects. Like he couldn't say like, my shirt is unbuttoned. He couldn't come up with the word for shirt. We're going fast. Great. Excellent. Okay. So his exam is notable for his Cincinnati is negative. His speech is coherent, but he's not really using the right words and he can't name the objects. So biggest things we're worried about right off the top. Any specific differential diagnoses that you're worried about? Great. Sugar, excellent. Metabolic issues. Stroke, fabulous. Fall, dehydrated, excellent. Excellent. Hypoxic, lovely. I would add infection in there just because we kind of talked about the abdominal pain is like, who knows what's going on with sepsis, but definitely cognitive impairment can kind of pop up. Are you doing anything therapeutically off the top of your treatment plan for this patient, or are we just getting somewhere fast? We'll say his saturations are fine. He's a little dehydrated based on his dry mucous membranes, and he really just kind of can't get the words out. Any specific treatments? Yeah, put him on the monitor, get an IV going. Excellent. Perfect. Okay, so just briefly, we've talked about strokes already a little bit, but some fun like specifics. These are just vocab words that you can very much impress all your friends with. Dysarthria is specific to like slurred or mumbled speech, like they can't quite use their tongue to get the words out correctly. Aphasia is specifically that they either don't understand what you're saying to them, or they can't say what they're trying to say to you. And so there's two different types of aphasia. Wernicke's, which is specific to this area of the brain and the left hemisphere. If you injure that area, you can't understand what people are saying to you at all. Or Broca's aphasia is also on the left hemisphere, and you can't speak the things that you want to say. And so very, very frustrating disease specific to the left hemisphere. And then apraxia is slower speech than normal. So they can get the words out, but it just takes forever. And this gentleman, unfortunately, was found to have a stroke in his brain. And he received treatment and hospitalization for that. But kind of a mild symptom to present with potentially that, otherwise seemed okay, but just his words were not quite right. So again, a lot of things to think about with altered mental status in older adults. Your differential is really broad. And this is just one of the many things to think about.